Diseases. In the previous lectures, we have covered about the salivary glands and the esophageal disorders or pathologies, and now we will focus on our stomach. So, first of all, revising some basic histology of the stomach is that it contains a lot of cells. Basically, first kind of cells are foveolar cells, or we can call them as goblet cells, and they secrete mucus, and the mucus is nothing but the combination of glycoprotein and water. Second type of cells is the parietal cells, and parietal cells secrete our main gastric acid or hydrochloric acid, and also the intrinsic factor. And intrinsic factor is also known as the Cassell's factor, which is required for the absorption of vitamin B12. Chief cells secrete pepsinogen, which is like precursor of the protease known as the pepsin, and also the gastric lipase. There are other kinds of cells like D cells which secrete somatostatin, which is a gastric inhibitor, and G cells secrete gastrin itself, which stimulates the acid secretion. These are some cell types, and these are present in particular areas of the stomach. For example, the foveolar cells or the mucus cells are present in the epithelium, okay, and below the epithelium we can see the parietal cells that secrete gastric acid, and in the purple color we can see the chief cells in this diagram. Chief cells secrete pepsinogen and the gastric lipase. Parietal cells are more towards the pinkish color, and the more empty cells with they secrete mucus, so they are empty. The general organization of the gastric mucosa and overall our gastric system and the GIT is very important. First of all comes the mucus, and mucus contains epithelium, the subepithelium known as the lamina propria and muscularis mucosa. Below the mucosa is the submucosa, and next is the muscularis propria, then comes the serosa, or we can say subserosa, and finally we have the serosal layer. The word suggests to us that gastro means stomach and itis means inflammation of the stomach. So there is some sort of inflammation occurring inside the stomach walls. So there are two types of gastritis, as you suggest that acute and chronic gastritis are there. First of all, we are going to discuss the acute, and then we will follow by the chronic. Acute suggests that it's of the short term. The gastritis is of short term, it's not of long duration. And causes are like drugs, I will explain them in a minute, alcohol, smoking, and spicy food, tea, coffee, also stress. Viral infections and bacterial infections can also be the cause of gastritis, also the bile reflux. How do the drugs contribute to the development of the acute gastritis as well as the chronic one? Because the drugs, for example, ibuprofen, naproxen, aspirin, and non-steroidal anti-inflammatory drugs, particularly NSAIDs, they block the production of prostaglandin E2, and as you know that prostaglandin E2 have a protective mechanism in the stomach. It protects the stomach walls from the gastritis, but when we take NSAIDs, the production of PGE2 is decreased and the protective mechanism is halted. So that's why we suffer from gastritis, or the patients who consume NSAIDs in large quantities, they can suffer from gastritis. So causes are drugs, alcohol comes along. The alcohol is the smoking, spicy food, tea, coffee, stress, infections, either it can be bacterial or viral, and bile reflux. How can stress contribute to the formation of gastritis? It's a very important topic. Let's discuss about it. Stress related mucosal damage, basically it means, and there are two types. First is the curling ulcers, and the second are the Cushing's ulcers. First is the curling ulcers. Curling ulcers develop in the patients who have burns, like these are also known as the burning ulcers. And think logically that burning is a type of stress. Our body recognizes the burn as stress. So these are the stress ulcers that develop in the patients who are burnt. And as you know that burning results in hypovolemia, because when our skin or the tissues are burnt, they result in the uh, deletion, or we can say degradation of our skin. And skin also contains water, right? So they result in hypovolemia. And when the volume of the fluid and the blood is lost in case of burning, it results in ischemia. Ischemia means that less amount of blood is supplied to the organs and the tissues. And these curling ulcers are superficial ulcers, right? They are occurring in the superficial wall or superficial part of the stomach wall. And as I have told you that these burns leads to a stress response that reduces the blood flow to the stomach lining and can cause the tissue damage, as well as it can occur in the duodenum. Because when there is hypovolemia, so it will result in ischemia, and this ischemia triggers stress response, and our stomach and duodenum cannot get enough blood flow, and it results in the damaging of the stomach walls and as well as the duodenum walls. So these are like curling ulcers. You can remember that curling and burning are like phrases, so we can use them simultaneously. These are types of stress ulcers. Second type of stress ulcer is the Cushing's ulcer. And Cushing's ulcer has some relation to the central nervous system, how it can happen. Cushing ulcer is due to the tension. Tension means in medical that there is elevated intracranial pressure or something wrong with the brain, something wrong with our cranium. It results, whatever is the cause, it resulted the elevated intracranial pressure. And when the intracranial pressure goes high, it suppresses the one of the nerves, which is the cranial nerve 10, which is our vagus nerve. And as you know that vagus nerve has parasympathetic supply to most of our body organs and body tissues, and vagus nerve is parasympathetic nerve overall. And when the vagus nerve is pressed, or it results in the overstimulation of this nerve, and it results in the paralysis of the sympathetic nervous system. But in contrast, parasympathetic nervous system is overstimulated. When parasympathetic nervous system is overstimulated, as you know that our rest and digest response become activated, and it results in more digestion. More digestion means that more of the acid is going to be produced, and it results in the hypersecretion of the HCl. And when HCl is in oversecretory state, it would obviously result in gastritis. These Cushing ulcers are deep ulcers and can occur in stomach, esophagus, and duodenum. So revising the Cushing ulcers, that it has relation to our intracranial pressure. High intracranial pressure presses the vagus nerve. It results in the overstimulation of the parasympathetic nervous system, result in the overstimulation or oversecretion of the HCl, and these are the deep ulcers and can occur in any region of our gastrointestinal tract. Coming towards the chronic gastritis, these, as the name suggests, that chronic means long term. It has to do something with the time course. Okay, it has the longer duration of action. There are two types of chronic gastritis, type A and type B. Also type C is present, but here we will going to discuss type A and type B. Type A suggests that it's autoimmune gastritis, and type B is bacterial gastritis. Discussing about the autoimmune gastritis, that in autoimmune conditions, in autoimmune diseases, our antibodies starts to attack our own cells. They recognizes our own cells as antigens or pathogens, and they start to produce autoantibodies against our own cells. In case of autoimmune gastritis, the cells which are attacked by the autoantibodies are the parietal cells of the stomach. And as you know that parietal cells secretes two things. First, they secrete HCl, and second, they secrete the intrinsic factor. And what is the function of intrinsic factor? Intrinsic factor has the function in reabsorption of the vitamin B12. But when autoantibodies attack the parietal cells of the stomach, intrinsic factor is going to be less secreted, and the vitamin B12 cannot be reabsorbed. And this is how the pernicious anemia or megaloblastic anemia would result from the autoimmune gastritis. When vitamin B12 is not being reabsorbed, it results in the vitamin B12 deficiency anemia or megaloblastic anemia. The second type of gastritis, which is more common among the population, and it's the type of chronic gastritis. It's the type B and so-called bacterial gastritis. When comes to the gastritis, the most common bacteria affecting our stomach is the Helicobacter pylori, also known as the Campylobacter pylori. And Helicobacter pylori would be affecting the antrum of our stomach, but in autoimmune gastritis, the part that is more vulnerable to the attack is the fundus and the body of the stomach because parietal cells are more in concentration there. So Helicobacter pylori or Campylobacter pylori is the is like a villain in causing the chronic gastritis, and it's most common among the population. Let's discuss about the Helicobacter pylori and some of its characteristics as well as the staining methods for the H. pylori. First, the properties of Helicobacter pylori is that it is a flagellated organism. Okay, flagellated means that it has a tuft of flagella, and this flagella helps the bacteria for chemotaxis. It can move along the stomach walls. It is a gram-negative species. Okay, it's a gram-negative bacteria, and it has surface adhesions. Surface adhesions means that it can adhere to the walls of the stomach. It has flagella, as I have discussed, and how this bacteria survives in such acidic environment of our stomach. This bacteria has urea, which is converted into ammonia. As you know that ammonia is alkaline in nature, and this ammonia neutralizes the acidity of our stomach, and in this regard our H. pylori survive in that acidic medium. The other most important genes that these bacteria are carrying is the SAG-A and VAG-A genes. The SAG-A and VAG-A genes are known as the cytotoxin associated gene, which is SAG-A. The VAG-A is the vacuolating cytotoxin A. These genes has nothing to do with the gastritis, but they increases the risk for the gastric cancer. These are present in that bacteria, and they over stimulate, or they are like more risk towards the development of the gastric cancer. Also, an important molecule which is present in the H. pylori is the BAB-A. What is BAB-A? BAB is the blood group antigen binding adhesion. Okay, blood group antigen binding adhesion, and it has propensity to bind to the blood group O. What does it mean? It means that the patients who have blood group O are more susceptible for the development of the gastritis, right? They have a lack of blood group association in them. When a person is affected by the H. pylori, the most common disease the patient would suffer is the gastritis. Peptic ulcer disease can also occur, and adenocarcinoma and maltoma will discuss in the later lectures that these are also effects for the H. pylori. But peptic ulcer disease can occur in the patients who have blood group O, and adenocarcinoma can occur in patients more frequently who have blood group A. So this H. pylori has some sort of blood group association. Let's talk about the stains that we can stain the H. pylori. These are for laboratory examination and diagnosing of the H. pylori infection. There are three types of stains that we are using now. First is the Warden-Sterry silver stain, and in this condition the bacteria are stained like black. Okay, you can see that H. pylori is stained in black color. It is Warden-Sterry silver stain. The second is the Gimsa stain, and Gimsa stain is a type of Romanovsky stain, and like Gimsa stain is a faster method for the diagnosing of the H. pylori. The third is the most common, and it is the urease test positivity test. It means that our bacteria, when placed in the urease environment, it is result in the pink color. How the test will indicate that it has positive results? Negative urea result will have yellow color and the positive urea result have the pink color. So we can identify that bacteria when placed in such samples are turned into pink color. Microscopic examination of the gastritis is that, as I have told you, that the organization of the gastric mucosa, it contains mucosa. Okay, we are only focusing on mucosa now. That mucosa contains epithelium and it has the subepithelium layer known as the lamina propria. In the histological examination of gastritis, we will see neutrophils in the epithelium and we will see plasma cells in the subepithelium or the lamina propria. So we are going to see neutrophils in the epithelium and plasma cells in the subepithelium or the lamina propria. Plasma cells have a very familiar shape. They have eccentric nucleus. It means they have not centralized, but they have like demarcated or location towards the periphery. They have nucleus right like this. So we can identify that these cells are the plasma cells. One most important recognition or diagnosing factor for the gastritis is the results bodies. What are results bodies? Results bodies are the inclusions of the immunoglobulins in the plasma cells that are present in the lamina propria. As you know that plasma cells are the B lymphocytes and these B lymphocytes secretes immunoglobulins or antibodies, and these globular inclusions of immunoglobulins are nothing but result bodies. What is the treatment for gastritis? This is just for an extract that treatment for gastritis are the proton pump inhibitors, all of our prozoles, omeprazole, pantoprazole, esomeprazole. These are proton pump inhibitors and they work by inhibiting the gastric secretion. The second is the H2 blockers. H2 blockers means that they block the function of histamine at the histamine receptors and they reduce the gastric acid secretion. This is for the acute gastritis. Okay, we are focusing on inhibiting the secretion of the gastric acid that has been the cause of our gastritis. In case of bacteria related gastritis, we can give patients antibiotics for the H. pylori. The third disease, as far we have discussed our acute gastritis, the chronic, and now we are going to discuss about the peptic ulcer disease, which is PUD. Peptic ulcer disease, it's like open sores. These are sort of ulcers that develop in the lining of our digestive tract. 70% of the people went don't notice any symptoms, but 30% can have some sort of symptoms. There are two types of factors that play a role when it comes to the overprotection and damaging the environment of our GIT. First are the damaging factors and the other are the protective factors. Damaging factors: H. pylori, HCl, oversecretion, pepsin, drugs, as I've told you that NSAIDs or like ibuprofen. Viral infection, cytomegalovirus can also has a damaging effect, and hypersecretory state, which is the hypersecretion of HCl and the stomach acids. The protective factors include mucus bicarbonate and cyclooxygenase 1. Peptic ulcer disease is going to occur when the damaging factors overcome the protective factors, when damaging factors have more role than the protective factors. So we discussed that NSAIDs block the production of prostaglandins, mainly E2, but how it going to block the activity of prostaglandins? It will block the activity of cyclooxygenase 1, and cyclooxygenase 1 is the enzyme that is going to produce prostaglandins from the arachidonic acid. A- And when the arachidonic acid cannot be converted into prostaglandins, how we are going to get prostaglandins? So it means that our non-steroidal anti-inflammatory drugs block the function of cyclooxygenase 1, and this is the enzyme that converts the arachidonic acid to prostaglandins, and prostaglandin secretion is low or prostaglandin formation is low which had mucus and bicarbonate. It had gastroprotective effects. But when the prostaglandins are low in quantity or low in concentration, it will result in the peptic ulcer disease. The symptoms, as I have told you, that 70% of the patients don't notice any symptom, but overall symptoms can have pain in the epigastric region, dyspepsia. Dyspepsia can also occur. It means that there is problem in digestion. Early satiety can occur. Early satiety means that we have eaten a small portion of the food, but we think that we have eaten a lot. It's the sign of early satiety. Burning sensation and bloating can occur. Also, nausea, vomiting, hematemesis means that vomiting with the blood, and melena, which are the stary or black stools, can also be the symptoms of the peptic ulcer disease. The most common gold test for the diagnosing of the peptic ulcer disease is the esophagogastroduodenoscopy, which is EGD. It's the gold standard for diagnosing the peptic ulcer disease. The second one can be biopsy. Barium swallow can also be done in case of achalasia cardia. We have also been doing barium swallow study. But in case of peptic ulcer disease, we can also do that. And for the assessment of the H. pylori infection, we need to do some sort of special test like serology, urea breath test, and stool antigen test. These are some tests for the assessment of the H. pylori infection, as H. pylori was also cause of the peptic ulcer disease, not only for the chronic gastritis. Treatment of the peptic ulcer disease are the proton pump inhibitors, as we have discussed in case of gastritis, like omeprazole, pantoprazole. They reduces the gastric acidity. In case of H. pylori infections, we can suggest patients some antibiotics, and antibiotics is known as the triple therapy in case of PUD. Like three kinds of antibiotics are used. First is the clarithromycin, second is amoxicillin, and third is the metronidazole. These three are used simultaneously for the treatment of the peptic ulcer disease. That's why we call them as triple therapy. We should avoid the non-steroidal anti-inflammatory drugs, as they were blocking the function of cyclooxygenase 1, right? We have discussed that. Also avoid smoking and alcohol. So this can be a sort of treatment. Peptic ulcer diseases can of the two types. First are the gastric ulcers and the second are the duodenal ulcers. Gastric ulcers are less common, but the duodenal ulcers are more common. Gastric ulcers occur in the lesser curvature of our stomach, and the duodenal ulcers occur in the first part of the duodenum. Okay, this part. It is also known as the D1, and the duodenal ulcers most occur in the D1 part of the duodenum. Peptic ulcers, when talking about the gastric ulcers, the pain occurs 15 to 20 minutes after eating. It means that this is the time when acid is going to be released. The pain occurs 15 to 20 minutes after eating our meal. But in case of duodenal ulcers, as the digestion in the stomach requires some sort of time, so duodenal ulcers would have nocturnal pain. Nocturnal pain means that the patient would come to you at night and he will say that I have pain in the stomach or in the epigastric region in night. And paradoxically to the gastric ulcers, the duodenal ulcers are relieved on taking the food, because our food contain some part of alkalinity, and it will block the acidity, it will neutralize the acidity, and pain would be relieved in that context, right? Complications of these ulcers is the most common complication is the bleeding, and when bleeding occurs, the bleeding can be in the form of hematemesis, means that vomiting with the blood, and melena means that dark stools are there. And in case of the gastric ulcers, the bleeding comes from the left gastric artery, which is the branch of the celiac trunk. And in case of the duodenal ulcers, our bleeding is going to come from the gastroduodenal artery, as the name suggests. The complication associated with death of the patient is the perforations. Okay. Perforations mean that there are some sort of holes that are present in the tissue of the ulcer, and in case of gastric ulcer, there can be the risk of cancers. Cancers can be developed from the gastric ulcers, but in case of duodenal ulcers, which are the type of the peptic ulcer disease, there is no risk for the cancer development, right? One of the complications of the duodenal ulcers is the gastric outlet obstruction. Now we are going to discuss the fourth disease. First, we have discussed acute gastritis, then chronic gastritis, then peptic ulcer disease, and now we are focusing on the gastric outlet obstruction, our last topic for today. It's the complication of the duodenal ulcers, and it has different causes in infants and the adults. In infants, the most common cause of the GOO, what we write it as the gastric outlet obstruction, or GOO, the most common cause in the infant is the infantile hypertrophic pyloric stenosis, i.e. IHPS. It means that there is the pylorus muscle thickening, and it results in the narrowing of the pylorus channel, and the food content cannot pass through that. That's why we call it gastric outlet obstruction. What sort of sphincter is present in the outlet part of the gastrum? It is the pylorus sphincter, right? And in the entrance of the stomach, there is the cardiac sphincter. But we are talking about gastric outlet obstruction, so something is wrong with the pylorus muscle or the pylorus sphincter. The infantile hypertrophic pyloric stenosis is the pylorus muscle thickening, and it result, we are talking about infantile hypertrophic pyloric stenosis now, that it results in the non-bilious vomiting, because bile is not the part of this vomiting, it's the non-bilious vomiting, because bile has not been yet mixed with the stomach contents, right? And the child or infant would demand repeated feedings, because through vomiting, all of the food contents are expelled out, and the child is still hungry, and he or she will demand repeated portions of the food. But the infantile hypertrophic pyloric stenosis is one of the cause of the GOO. Formerly, it was called as congenital, like IHPS was called congenital, because there is like trisomy of 18 and trisomy 21. Trisomy 18 is the Edwards syndrome, and trisomy 21 is the Down syndrome. But now we can say that after the birth, in 1 to 2 weeks of the infant life, if the infant is exposed to erythromycin or azithromycin, the child can have GOO. GOO is not only congenital, but it can also be acquired. But when the child is exposed to some sort of drugs like erythromycin and azithromycin, it can result in the formation of the gastric outlet obstruction. What is the treatment of the gastric outlet obstruction? It is the pyloromyotomy, because the problem is with the pylorus part or the pyloric sphincter. In the adults, the most common cause is the pyloric stenosis, peptic ulcer disease, and the stomach cancer. They can all result in the formation of the GOO. And the symptoms include, like same in all of the diseases of the GIT, pain in the epigastric region, and the vomiting would be projectile, and it would be repeated vomiting, because the food contents cannot pass through the pylorus, and it contains undigested material in the vomiting. Two most important symptoms as far as GOO is concerned: first is the metabolic alkalosis. Why alkalosis? Because HCl, which is hydrochloric acid, which is present in the stomach, would be expelled out through the vomiting, and the body will suffer from metabolic alkalosis. Also dehydration, because water has been expelled out also, and paradoxical aciduria. Paradoxical aciduria is due to when there is loss of hydrogen and the chloride ions in the vomiting, the body suffer from metabolic alkalosis. Okay, there are lot of alkaline material present in our body, and we would suspect that the patient would have alkalinuria. Okay, the patient would have alkaline urine, but in this condition the patient is having paradoxical aciduria. Why is that so? The kidney conserves sodium because our body is suffering from alkalosis. So kidney starts to conserve sodium. It will reabsorb sodium and excrete hydrogen ion as well in the urine. So when the hydrogen ions or protons are present in the urine would be acidic. So that's why the patient will suffer from paradoxical aciduria and metabolic alkalosis in case of the gastric outlet obstruction. This was for today, and in the next lecture we'll discuss about some other pathologies of the stomach. And so far it's enough for today. I will see you in the next video. Till then, goodbye.